Good morning, everyone. It's 8 a.m. in Colorado, so we're going to start our monthly International Colorectal web meeting. So today we have pediatric surgeons joining from Canada, Mexico, Brazil, Colombia, South Africa, Algeria, Saudi Arabia, Turkey, Trinidad and Tobago, Chile, Sri Lanka, and Libya. If I did not mention your India, if I did not mention your country, please type in the chat and we will acknowledge at the end. So the first presenter is Dr. Johanna Cardosa from Hermosillo, Sonora in Mexico. So welcome.
Good morning, thank you. Can you see my screen?
Perfectly, okay. Thank you.
So this is the first case. This is a patient who was first treated and operated on an outside facility. This is a newborn male who passed meconium during his first 24 hours of life and had a normal anus. On day 2 of life, he presented with abdominal distension and poor feeding. He was treated with nothing by mouth and only observation. The next day, on day 3, they took more x-rays, as you can see, with a very distended bowel. With this history and image, what would be the next study you will order? An upper GI with small bowel follow-through, a contrast enema, an abdominal x-ray, or an abdominal ultrasound. Okay. On day 4 of life, the patient still had abdominal distension and he had progressive deterioration of his general condition. So which study will you do? An upper GI series with a small bowel follow-through, a contrast enema, an abdominal x-ray, or an abdominal ultrasound? They asked for a pediatric surgery consultation. They did an X-lab with the pre-op diagnosis of bowel obstruction. They did a colostomy in the sigmoid, and they found bowel dilation without any. 2 months after the colostomy, they did a contrast enema and found a non-distended colon, as you can see right here.
We lost your presentation.
We lost your presentation, Johanna. We lost you for a minute and your presentation disappeared.
Okay, there, can you see it now?
Yes, we can, thank you.
Okay, so after the colostomy creation, the patient started feeding, his general condition improved, and he was discharged home 10 days after the surgery. 2 months after the colostomy, they did a contrast enema and found this non-distended colon. Will you do a colostomy closure with this image, yes or no? And which study will you do prior to the colostomy closure? An anorectal manometry and a transanal rectal biopsy, an open leveling colonic biopsies, or a proximal contrast enema? With the previous contrast enema, 2 months after the colostomy, they did a second X-lab and they took biopsies from the right transverse left colon and the rectosigmoid. They also did an appendectomy. They closed the colostomy, but they created an ileostomy. And pathology reported presence of ganglion cells in the right colon, the transverse colon, but absence of ganglion cells and negative calretinine in the rectosigmoid. What would you do next? Transanal rectal biopsy, a pull-through and ileostomy closure, a pull-through and ileostomy, a pull-through with ileostomy closure, but a colostomy creation.
Let's give people a couple seconds to vote here. Hold on.
Okay, sure.
And there are the results.
It's just that I cannot see the results or anything.
Oh, sorry.
Don't worry.
So the majority said pull through and ileostomy, 63%.
Okay. So 2 months, sorry, after that, the leveling biopsies and that ileostomy, they did an open Swenson-like pull-through and an ileostomy closure. In 1 month after the pull-through and the ileostomy closure, the patient presented again with significant abdominal distension and poor feeding. They changed the milk formula and prescribed simethicone. What is the cause of these obstructive symptoms? Anastomotic stricture, ischemic pull-through, Hirschsprung-associated enterocolitis, a twisted pull-through, and a ganglionic pull-through, or all of the above?
And we have an answer in 1 second. Looks like all of the above.
Okay. What will you do next? A contrast enema, an exam under anesthesia with Botox injection, an abdominal x-ray, an exam under anesthesia without Botox injection, stimulant laxatives, or rectal irrigations?
Let's see the answers. And the majority said rectal irrigations, 45%, and 30% contrast enema.
Okay. They did a contrast enema where you can see a very, very distended colon right here. This is the lateral view. Very distended.
So, Johanna, you need to show the distal segment of the pull-through.
This is the distal segment of the pull-through, right here. And then the very distended colon, the lateral view, the distal segment right here, and the distended colon. 1 month after the pull-through, they did an exam under anesthesia, they did anorectal dilations with Hager 18, and the mom said after the dilations, the patient started having many bowel movements. What will you do next? Anorectal dilations, rectal irrigations, colostomy creation, ileostomy creation, Botox injection, or I don't know?
We'll wait for a couple more votes.
Sure.
It looks like rectal
Majority
irrigation.
suggested rectal irrigations, 42%, and 26% anorectal dilations.
Okay. 2 days after the anorectal exam and the dilations, they decided to do an end colostomy with a Harman pouch. They found significant rectal stenosis and a bowel perforation 5 centimeters proximal to the anastomosis. Then the patient came to the colorectal center in Colorado. The patient had normal growth, but he had an end colostomy with severe prolapse, but without any obstructive symptoms. This was approximately 7 months after the colostomy creation in the previous hospital. We did an exam under anesthesia. The patient had a normal anus with an intact anal canal, and he had an acquired atresia at the anastomotic site, approximately 2 centimeters in length. Then we did a contrast enema through the colostomy, where we could see, we saw this 30 centimeters of proximal colon left right here. This is the the colostomy. What would you do next? A transanal pull-through, a pull-through and ileostomy creation, a pull-through and a new colostomy, or I don't know.
And people are voting. And here are some results. So it looks like the pull-through and ileostomy creation got 57%, and the transanal pull-through got 26%.
Okay. We took the patient to the OR. We did a total body preparation, and we started with an X-lab and taking down the colostomy. We cut the blood vessel right here, making sure the colon had a good blood vessel supply so we could have more length of the colon in order to do the pull-through. The previous pull-through was closed in a Harman pouch with staples, and it was stuck with the posterior wall of the bladder, and the distal portion of the new rectum was stuck with the posterior wall of the urethra. So this was all fibrotic, ischemic, and filled with mucus. And this distal end right here was arthritic, and the atresia was localized in the dentate line. We also identified both ureters, and the left ureter was stuck with the previous pull-through. Then we did a transanal approach, and we dissected the distal neorectum, which was also fibrotic. After 2 to 3 centimeters of mobilization, we observed the Foley catheter right here, as you can see, through a hole in the vulvar urethra. Then we did a posterior sagittal approach, and we were able to open the posterior wall of the anal canal. We did a dissection of the neorectum, which was also stuck over the urinary tract, and we resected this segment of bowel. And we also did an urethroplasty in 2 layers. There was actually no presacral space right here to perform the pull-through. This was all semen-like between the sacrum and the posterior wall of the bladder. So in the end, we talked to the mom. We gave her the option to continue with the pull-through, having the risk of urinary tract injury and other pelvic structures, and a very high risk of fecal incontinence as an outcome. The second option was creating an colostomy. So the mom decided to do the colostomy. We went back to the OR and created it, and this is how he looks now. The biopsies from the neo pull-through that we dissected were positive for Hirschsprung's disease. After 2 months, the patient is asymptomatic. He has had no prolapse of the colostomy. He's eating well and growing normally. Thank you.
Thank you, Johanna. I'll let Dr. De La Torre comment because he knows a lot about this case. But I just want everyone to really think that this is a very tragic case. This was a patient that was born with the most common type of Hirschsprung disease, rectosigmoid, and now is a patient that has an colostomy. So I think we should not take our job lightly. And it's very sad to realize that a patient that was supposed to have a very good outcome now has a sequela for life. So Dr. De La Torre.
Thank you. Good morning, everyone. Yeah, thank you, Johanna, for this presentation.
Thank you, doctor.
The idea of this presentation is to show you what happened when something started wrong. When we read the report, the initial report, this patient had Hirschsprung with 6 centimeters of a ganglionic bowel. So it was very short segment. I think the decisions that they did in the other hospital were not the best. big concern always was why he was always sick after the pull through. And I cannot believe how a baby can survive several weeks with a rectal perforation, which was the uh, transoperative findings when the surgeons uh, redo the colostomy and create a Hartmann pouch and close the perforation. So when we tried to do the new pull through, all the pelvis was like a cement. It was super fibrotic. The rectum and the urethra was like just one structure. So the decision to do this operation was based on not to create more damage. He already has a lot of damage. If we go back to the initial history of this patient never passed meconium, for at least for the initial 4 days. Here in the United States, one of the protocols is to rule out initially malrotation. So they usually do upper GI to rule out malrotation because the patient was not malrotated. They believe it was just, I don't know, enterocolitis related in the newborn. We don't know what happened. But at the end, several days later, the surgeon decide to do a colostomy. They didn't find anything during the X-lab. So they decided to do the colostomy, but they never took a biopsy from the rectum. They took a biopsy from the colon. And remember, when you do a laparotomy in a newborn with these clinical features, you need to think in Hirschsprung. If these surgeons, when they create a colostomy in the newborn period, they were able to do a transanal rectal biopsy or rectal biopsy, suction rectal biopsy, any kind of rectal biopsy, for sure they will have the diagnosis of Hirschsprung, and then they will have a good plan. Unfortunately, this patient was submitted again to another X-lab to do several biopsies from the colon and the rectum, and then create an ileostomy. So many things I think they were wrong, but this is I want to say a very sad example, but we want to show you what could happen when a surgeon is not exposed to this problem. I mean, they do few patients of Hirschsprung per year. Probably this surgeon is doing a Hirschsprung every 10 years. So if you don't have experience or you are not exposed to this entity, please refer the patient to another surgeon. At the end, the patient is going to live with an end colostomy. Now he's healthy, but he's going to live with an end colostomy. I don't know if there is any question in the chat.
There is one question. Why didn't you finish the dissection through the abdomen like a suave?
The patient already had a suave, well, like suave, because they said Swenson, but when we read the description, they start to do like a mucosectomy and then full thickness from below. All the pelvis was, I don't want to say fibrotic, because fibrotic does not describe the reality. It was a stone, it was a rock, like a cement, all the pelvis. So it was, I don't want to say impossible, but we can finish the pull through, but we can, in fact, we open the urethra, and that's why we have to repair the urethra. So I think it's not fair for the patient to do a pull through when you find this type of pelvis. Any other question?
I don't think there are other questions. I just want to make one comment too. Just looking of or suspecting how unexperienced the team that did the initial pull through were. when you look at the reports of the biopsies, they send the appendix, and the report of the appendix is no malignancy. So I think we all in this audience understand that if you are doing serial biopsies for Hirschsprung and you send the appendix, you want to look if there are ganglion cells in the appendix or not. We are not suspecting malignancy. So I think that's also a hint of how inexperienced the team was. It's a very sad case, but unfortunately, it is common. We're going to publish soon our global survey, but I was shocked to find that 25% of patients with Hirschsprung suffer from severe complications. So 1 in every 4, it's too much. We cannot continue like that. So thank you very much, Johanna, for presenting. Thank you, Dr. Deep, for your
Thank
comments.
you, doctor. Thank you.
And thank you to Dr. Evans for this collaboration.
So we're now
Yes, thank you to Lauren.
So now we're going to move to the second case that will be presented by Dr. Abdullah Zaleh from University of Alberta, Canada.
Good morning, everyone. Thank you very much, Dr. Bischoff and Dr. Pena and Ray for this opportunity. I'm presenting from Edmonton, Alberta. This is a case of that really I'm presenting for advice and for your consideration instead of really to tell you what happened. It's a 14-month-old that's in our practice right now, born by C-section at 37 weeks of life. Prenatally, we saw that she had oligohydroamnios from 19 to 23 weeks, and there was suggestion of lung hypoplasia. They also noted caudal regression and sacral dysgenesis, both on the ultrasounds and then eventually on a fetal MR. There was an absent left kidney. Initially, it looked like a mass that was developing, and then subsequently it settled on an absent left kidney, right hydronephrosis, and hydroureter. There was a fetal perineal cyst with complex abdominal mass in left lower quadrant, which was thought to be this left kidney, bowel obstruction, perforated anus, and anorectal malformations. Postnatally, when baby was born, the imaging and the picture looked like a caudal regression syndrome with cloaca and absent left kidney. This is how the baby initially was born, and the initial call that I had was that we have a male boy that might be intersex and got transferred to our facility. When I examined the child, there was really no opening out here. It was very, very challenging to find something small, but it looked like a female, and then we at least suggested that it was a female. Then we started the workup. This is the original X-ray for the child. You can see there's not much in terms of very distended loops of bowel, but you can see that the sacrum and the vertebrae are highly abnormal on this babygram. So an ultrasound was done on day of life 1, which showed what we suspected, the solitary right kidney with moderate pelvocalcitasis and ureteric dilatation. There was significant parenchymal thinning, and the bladder was markedly distended, and the bowel was also markedly distended. There was no urine output at this time. There was unsuccessful attempts of catheterization, and obviously, given the very, very tiny, if almost non-existent opening, and the patient received a suprapubic catheter at day of life 1 by urology. It was a percutaneous kit, and underwent a spinal MRI a few days later, which showed sacral dysgenesis. The conus is low-lying at L4. So at this point, we had a long discussion with the family, and we performed a divided colostomy and mucus fistula at day of life 2. I learned my lesson of doing a looped colostomy the last time I had a cloaca, and subsequently Dr. Bishop and Dr. Pena came to Edmonton to help me with it. And I think 10 hours into the case, Dr. Pena leaned in and said, "I thought I told you never to make a loop colostomy." And I thought I learned my lesson at that point. The patient had a suprapubic catheter, as I mentioned, but it stopped working, and he needed a she needed, pardon me, a vesicostomy creation at day of life 6, and so that was taken by one of our urologists to perform that. This is the MRI that we subsequently obtained to try to delineate the anatomy now at 14 months of life. So you can see the abnormal sacrum and the low-lying conus. The Foley is in the vesicostomy and trying to figure out the anatomy, and this is the distal colostogram. Sorry, it's a video. It'll just take a second to run through. You can see the composite here. That's the colostomy is left, sorry, the mucus fistula in the left, and then heading down towards the bladder, and then we suspect connects into the bladder neck. And you can see the abnormal sacrum here, and then back up again. And then this picture, which this balloon is not very well timed, but this was in the mucus fistula, but there's no pacification in this phase. The balloon here is in the bladder, and you can see the very abnormal right kidney, a mega hydroureter. And I have more images. Dr. Bischoff, do you want me to continue going through images, or we can just skip?
I think we can skip. I think we have what we need.
Perfect. I'll just skip ahead to the to really the discussion now that the family is from Edmonton. They are from a lower socioeconomic background, and they would wish to have a complete repair from a neurological symptoms. It was initially thought by neurosurgery that this child would never walk, and given her significant abnormalities in her sacrum and her caudal regression. But she has been taking some steps. She has quite a wide gait, and at 14 months can stand. And so I think the parents are quite encouraged that she's done better than the neurosurgeons thought. Her continence must be better than what we're suggesting, and that they wish to proceed with a repair, a complete repair. There's also a bit of a complicating factor where her creatinine has been climbing, and so the urologist is also feeling the pressure of looking at a ureteric reimplant for this child. And so, but we wanted to discuss this case because I think, one, ultimately our imaging is not great. We tried, and we could have gone through some of the imaging, but I don't think it would change much. We couldn't get very good imaging. Do we need to repeat the imaging at our facility or elsewhere? What's really the prognosis on continence in a child like this? And should we proceed with offering a repair in our center or send the patient elsewhere? And then also for discussion, what are some of the vaginal reconstruction options, given how very small or non-existent her vaginal cuff is. So I'll stop here, and maybe we can open it for discussion. Thank you.
Thank you so much, Dr. Saleh. If anybody has questions, please type in the chat. So I have several comments. Number one, when patients have the iliac crest and they have S1 and S2, like this patient has, those patients walk. I have never seen a patient with that type of sacral anomaly that doesn't walk. The only patients that do not walk are the patients in which the iliac crest is completely fused. There is no piece of sacral bone. So number one, this patient will walk. Number two, we know this patient will have fecal incontinence and neurogenic bladder. That's a fact. There's no way out of that, and it's very important that the family understands. Now, because of that, that's not a contraindication to reconstruct the patient, because she can have a good quality of life with reconstruction. In this patient, the most important thing is the kidney. She has one terrible kidney. So the chances that she will end up in kidney transplant are extremely high. So that's also another important factor why she needs the reconstruction. We have to separate the bowel from the bladder, because otherwise every time she has a urinary tract infection, they culture and it serves for nothing. It will always come with contamination, and we don't know if we're treating the patient well or not. So the patient, what I don't know is if this patient has a massive reflux or if this patient has a uretero-vesical junction obstruction. And I think that's important to clarify, to determine if she needs a reimplantation. Well, she will need a reimplantation regardless. But I would just, at this point, I think I would take care of the ureter with a reimplantation and open a very well-drained vesicostomy to make sure that this urine is free flowing to protect this kidney. Separate the bowel. I'm concerned that you don't have much length from the mucus fistula to down, because it goes to the bladder and seems to be tight. So you have to be prepared to take down the mucus fistula and bring as the anus. And at that time, you're gonna inspect to see if the patient has Müllerian structures. All cloaca patients, they have normal ovaries, fallopian tubes, and then you're gonna see if there are real uterus or if they are atretic. And then the vaginal reconstruction. Currently, when patients don't have a vagina, what we are currently using is alloderm. But I don't recommend using alloderm if you don't have anything to attach to. So if the patient doesn't have a uterus at this moment, I would not reconstruct, because otherwise she would need dilation, and we don't think it makes sense to dilate vaginas in little girls. So a few options. If the family really wants to full reconstruct, which I think is the best option for her, you can use this distal rectum that is short as vagina and bring down the proximal colostomy as rectum. The family needs to understand that her future will be daily enemas and daily catheterization. And if there is no uterus, there is no pregnancy for her. Do you want to comment? Questions, comments? Let me see if there is anything. Abdullah, what else do you want?
So I guess, I mean, really, you've seen the anatomy, and the one question is, I completely hear you on the importance of the ureteric reimplant. In centers, even though our center in a Canadian sense is one of the larger ones, like it's us and sick kids in terms of size, and patient referrals, but no center in Canada sees a lot of cloacas. And so I think I might have done the most cloacas in our group now, and a big number of that came from your guys' visit. So the question is, reimplanting the ureter, will that cause or burn any bridges in terms of subsequent reconstruction options, or in terms of figuring out the anatomy subsequently if we don't reconstruct now? And two, are these cases, given the fact that you really get one good chance at doing, is this something that should be done in centers that don't do that very often, or do you feel like this is not a very complicated cloaca in this, it's a long channel, but it's not necessarily a very complicated one? You think that is something we should attempt here?
Let me say something about the ureter and the bladder. The patient has a mega ureter, and the image of the bladder is not clear. To me, it looked like a tiny bladder, if I'm not wrong. So to try a reimplantation with that mega ureter and tiny bladder will not work. So what the patient needs is to first, as Dr. Bishop said, to clarify whether or not the patient has real reflux or actually has a uretero-bladder obstruction. See? So if the patient has a uretero-bladder obstruction, but the patient, yes, needs a reimplantation, but not with the purpose of avoiding reflux, and needs a vesicostomy. In other words, and if the patient has big reflux, I will do a vesicostomy. The vesicostomy will drain the bladder and the ureter for long terms until that ureter takes a normal kind of size and caliber. So reimplantation with such a huge ureter in tiny bladder that otherwise neurogenic is not going to work. So if the patient has an obstruction between the ureter and the bladder, take care of that obstruction and open a vesicostomy. Well, the idea, but to protect that kidney, is to have the easy way to drain, to decompress, and see with time what kind of kidney function reserve the kidney has. So that's my only comment about that.
And the child has a vesicostomy presently, but given the hydroureter, you feel that this is not adequately draining and that it should be revised?
So if the patient already has a good vesicostomy that is draining and the megaureter persists, that means that there's an obstruction between the ureter and the bladder and needs not so much of a reimplantation, but making that orifice larger to have a free drainage of the ureter into the bladder and outside. And then planning the reconstruction for later in life, they will need an evaluation of the quality of the bladder, which I don't think is going to be very good.
Okay, so those are the steps then we'll take. So we will try to, I mean, it would be hard to evaluate reflux versus an obstruction, but it sounds like this is obstructed because the child has a vesicostomy, and it seems like quite a wide one from our exam. So it sounds like the child needs a laparotomy and try to reopen that orifice between the bladder and the ureter as the first step. And you would not reconstruct, Dr. Bischoff. You were like at this stage, you would grow the child, and then even the parents could be reassured that, okay, this can be done down the road, and then reconstruct them down the road, like when the child is 4 or 5.
We don't delay the reconstruction. The only thing is a big operation in a kidney that has no good function sometimes push patients on dialysis. So I don't think this patient is there yet. You said there's just a bump in creatinine, so hopefully she still has some kidney function. But I would not delay reconstruction that long for the reason that if she gets urinary tract infection and the bowel is still connected, the cultures are impossible to evaluate. You don't know if what you're treating is correct or if it's just contamination because the bowel is right there attached to the bladder. So I think urgently she needs to open that ureter connection to the bladder to see if that improves the hydronephrosis, and it should improve fast. And then you can plan for reconstruction. Now, the question about where to reconstruct, of course, it's a difficult one for us because I honestly think cloaca patients should be referred to a center. But I know this is a very controversial subject, but I think it's a disease that it's rare enough. And patients have one chance to have the right operation. I think the first case was a good demonstration that even in the best hands, reoperations are not the same success as the first operation.
Absolutely.
So we normally operate on cloaca patients early in life, so before 6 months of age. And because of the caudal regression, we still offer the operation. We still do the reconstruction for the same reason. We need, in order to protect the kidney, we need to separate the bowel. We need to find out what's the anatomy. If there is vagina attached to the bladder, we have to separate. So we strongly feel these patients should have a repair. And it's about explaining to the family what's the future. The future is she's going to do enemas every day and she's going to do intermittent catheterization. But delaying the repair will not change that. That's the future of this child. That's the way she was born.
And there was a question in the chat about would a ureterostomy be a good option to relieve the obstruction at this age?
That's an option too, to open a ureterostomy.
Yes. In general, is not in a patient like this, it is not necessary to open a ureterostomy. If the patient has a vesicostomy that will drain the ureter, provided there is no obstruction between the ureter and the bladder. Otherwise, he will have two stomachs, vesicostomy and ureterostomy and a colostomy. That would be more. I think at this point, the priority is to give that kidney the opportunity to function, to see how much function it has. Because if the patient, if you delay that, the patient will have serious problems. And then with a adequately drained kidney and drained urinary tract, then you can watch the baby's quality of life in the following months with a good stomach and the vesicostomy draining, and see if the baby is growing, see if the kidney function is good, because that will be the priority for the baby's life.
Thank you very much.
Thank you. So we're going to move to the third case that will be presented by Dr. Eliani Hefty from Instituto Nacional de Pediatría in Mexico.
Good morning, everyone.
Can we expand your presentation out?
Sorry. Yeah, I'm sorry. Okay,
Perfect.
ready.
Thank you.
Good morning, everyone. It's a pleasure to be here with you today. We would like to share the case of a patient we treated a few months ago in the Institute. Well, this case is about a 5-year-old male patient whom we met in the clinic with the diagnosis of rectal prolapse with episodes over the past 3 years and chronic constipation. His medical history included allergic rhinitis, episodes of recurrent respiratory infections with hospitalizations due to pneumonia, and controlled asthma and ADHD. During the evaluation of chronic constipation prior to being referred to our clinic, they performed transrectal biopsies, which they reported as normal ganglionic. And in the directed questioning to the patient, well, the mother, she mentioned that the patient had bowel movements at 48 hours of life. In the past 3 years, he was treated with different types of laxatives, including a final regimen with stimulant laxative with senna, and in the 5 tablets every 24 hours. And with this treatment, he had bowel movements every 2 or 3 days, with daily soiling and rectal prolapse every 3 days, which spontaneously reduced. For us, during the evaluation, we rule out food allergies, intestinal parasitosis, and other causes of rectal prolapse. And the presence of recurrent respiratory infections was concerning for us, so we requested a consultation to pneumology to rule out cystic fibrosis, and the sweat test came back negative. So the management focused on his asthma with inhaled steroids. During the diagnosis approach, we performed a contrast enema. I'm gonna put the video. Okay, so we can see in the video that there was like a significant dilation of the rectosigmoid, and we didn't see other visible abnormalities. So since organic and functional causes of the rectal prolapse were ruled out and medical treatment was unsuccessful, we decided a scheduled surgical intervention. So in the preparative plan, the patient was admitted 48 hours before surgery. We administered oral metronidazole and given prophylactic antibiotics according to our post-surgical protocol. we decided to perform a modified DeLorme procedure to manage the rectal prolapse of the patient. So in the operating room, a urinary catheter was placed first, and the patient was positioned in prone position with the pelvis elevated. Then we placed the Lone Star retractor, as we can see here, positioning the hooks symmetrically at the boundary between the skin and the anoderm, you can see here. And then we can, so we can protect the pectinate area. And then we reposition the hooks, them like 1 to 2 centimeters proximal to the pectinate area to protect the anal canal and work safely, as shown here in this image on the right. So we can see here that the pectinate area is protected. Once the pectinate line was protected, we placed traction sutures with 4/0 silk, as we can see in this video, approximately 2 to 3 centimeters above the pectinate line to facilitate our work. And then we start a circumferential mucosal incision. Here, I'm gonna put the video too. As we can see in the video on the right, using electrocautery and blunt dissection. And it's important to notice here that it's essential to identify the circular layer of the muscular cuff, as shown here in the video. And then when we identify the correct plane in the surgery, we continue the mucosectomy until we reach approximately 1.5 to 2 times the length of the original prolapse. And in this case, we extended till 10 centimeters and show, as we can see here in these videos. Oh. So then we perform the muscular cuff plication with non-absorbable sutures, placing first sutures at 3, at 6, 9, and 12 o'clock. And then we place intermediate sutures, ensuring without no tension. In this image, you can see here how the muscular cuff here is properly plicated. And after that, we perform the colorectal anastomosis, resecting the excess of the mucosa, and then suturing the anastomosis with simple 4/0 bicryl stitches, first cardinal and then intermediate. As we can see here, we put the intermediate stitches, and and after we completed the anastomosis, we removed the Lone Star retractor and reduced the rectum into the pelvis. So in the postoperative course, we initiated the diet at 48 hours and continued osmotic laxative for the management of the constipation, and the patient was discharged 1 week after surgery to home. Well, for discussion and conclusions, it is important to emphasize that most patients with rectal prolapse do not require surgery. And we have to do a diagnostic approach, like really exhaustive, and should be all medical treatment options should be exhausted before considering surgical intervention. And we know that there are various surgical options available, and however, the literature suggests that the modified DeLorme procedure has the lower recurrence and recurrence and complications rates in pediatric patients. In this study by Dr. De La Torre, reported on 14 patients with idiopathic rectal prolapse who underwent the modified Delorme's procedure, and they reported that there wasn't with no recurrences or postoperative complications, and all patients had adequate fecal control. So this is something that we have to consider before planning our surgical intervention, and always remember that we have to do everything like medical treatment before we plan the surgery. So that concludes my presentation. I don't know if you have any questions or comments.
Thank you very much, Dr. Eliani. I think what I enjoy the most is how neat the videos were. I think I was lucky that I saw Dr. De La Torre seeing this operation, but I think it's very hard to understand if you actually don't see it. So I really appreciated the videos showing the mucosectomy and then how the plication. I think we just need one video of the actual plication of the muscle cup, and then everybody will be able to understand. Do you want to comment?
Yes, congratulations because it's during the entire presentation we did not see a drop of blood in the towels. This is the cleanest operation that I have ever seen. I don't know how you achieve something like that, but certainly you must be congratulated for such a elegant, neat, clean presentation. Now, I'm familiar with the Dr. De La Torre's modification of the Delorme procedure. And for that, the people who watch this presentation, I don't think they will be able to catch exactly what the procedure is. You need better diagrams to show what the plication of the seromuscular layer is something that must be shown with good diagrams. And Dr. De La Torre has those diagrams. And so people can understand, because if somebody just watches this and tries to do something similar, most likely will not be so successful. So congratulations for the technique. It's a very ingenious technique. I have had the privilege to assist Dr. De La Torre doing that, and I'm very happy with that. And we don't discuss the successes. This is a successful case. Congratulations. And again, congratulations for the elegance and cleaning.
Dr. De La Torre, do you want to put the link for the article, or for, I don't know if you have in your YouTube channel.
Yes, I can do that.
Perfect. So we're going to move to the last case that will be again presented by Dr. Abdullah Saleh. Thank you very much, Dr. Eliani.
Thank you very much again. So this is a different case, and I'm also looking for discussion and advice on. It's a case that was done at a different center and was subsequently referred to us. 12-year-old previously operated on due to a complex cloacal malformation. She also had a tether cord and sacral agenesis. She was a long channel cloaca. So the cloacal repair that was performed by pediatric surgery and pediatric urology at that center, they did a perineal and abdominal approach combined, performed a urogenital mobilization. They did perform a left salpingectomy at that time because they felt that during the urogenital mobilization, they could not get enough length, so they sacrificed the left tube. And despite that, could not make it all the way down to the perineum. So they ended up doing tube vaginostomy and creating some skin flaps to be able to provide a bit of coverage, as well as the cystoscopy. At the time of that surgery, it was noted that they saw a single vagina and a single cervix with a common channel that was approximately 5 centimeters. They mobilized the rectum partially. Like I mentioned, the urogenital mobilization was started and it was mobilized all the way to the level of the bifurcation, but because they couldn't bring it down, they switched to a laparotomy. Then they did a phanesteal incision, separated the bladder, reconstructed the common channel as the urethra, but because of the lack of ability to reconstruct the vagina, they performed a tube vaginostomy. The patient subsequently did suffer from urethral atresia and needed a vesicostomy. About a year later, she was struggling with multiple UTIs, and patient was struggling in that center. They went to a different center, also in Canada, and had a bladder neck closure, Mitrofanov creation, and vaginal reconstruction using a allium interposition as well as buccal mucosa, and that was done at the Sick Kids Children. And she did quite well from that time for the next about 9-10 years. She was doing okay. She did start to have cyclical pain at the onset of puberty and was found to have a left ovarian cyst that was enlarging and also a right-sided hydrosalpinx. By November 22nd, that right hydrosalpinx was now being called hematosalpinx. This is just a picture of the surgery that was performed in sick kids, just to better understand the rectum there was anal stenosis, so they had to revise that and dilate her. They brought an alveolar vaginal cuff, and there was also some buccal mucosa here that they put, and they saw at that time they thought that there was they thought they could see one cervix, but they realized that this was a hemiuterus, a didelphys type hemiuterus at that point, with likely an obstructed hemiuterus that was causing some complications. So she's then started this cycle because of having this recurrent abdominal pain, had 3 MRIs, and I'll go through them quickly. The first one from April 23rd showed that didelphys morphology. There was a large left adnexal bilobulated mass that was thought to be the left ovary, and there was in the right adnexa a dilated tubular structure coming from the left uterine horn, which almost felt like it was spun on itself, suggestive of moderate to severe right hydrosalpinx. The MR about 3 months later showed a hematometrocolpos in the left uterine horn with massive unilateral hematosalpinx, and they thought that there was distal vaginal stenosis and a distal vaginal septum. That's when things started to get very complicated, because I think the initial surgery, the anatomy was not necessarily clearly understood, and that I think caused a lot of back and forth for the family to be stuck with groups that were saying 2 very different things. They felt that the stable left adnexal cyst was not needing to be addressed, but given her pain for suspected outflow obstruction, they started her on Lupron. I saw her in April when the family was frustrated by what was going on. They came to our center to discuss what are potential other options given this pain, and also they did not really want to be on Lupron. They wanted her to be able to start having periods. We redid an MR and showed redemonstration of the uterine didelphys. The hematosalpinx was resolving, but she was or resolved, and she looked like she was adequately suppressed, but she kept having this cyclical pain in her right abdomen. These are and Dr. Bischoff, thank you for paring these down. This is the cross section. We can see the left hemiuterus here with a lot of enhancement within. Looks like it still has a lot of blood, and the right hemiuterus. This big cyst, we think it's the ovary, and you can see it here in another cross section. I'm just going quickly for the sake of time. This is another shot of that. So presently, the patient and the family really wish to be off Lupron. They don't want to continue vaginal dilation, wish to have normal menstrual flow. The gynecologist in Sick Kids, and so now there's 3 or 4 centers that are involved in this girl's case, and it's getting more and more complicated. They felt that, I quoted them, unusual to have unilateral obstructed outflow tract that is symptomatic in absence of bleeding from a connected site, especially on Lupron. So the questions that I had was, should she come off of Lupron, which is what I had initially suggested? Would a hemi or total hysterectomy be advisable? They are asking for a total hysterectomy, and I felt that was aggressive. Maybe a hemi in the right setting with the right people, and then would a scope to evaluate the vagina cervix for outlet obstruction be useful at this point? Thank you.
Okay, Dr. Abdullah, you have very complex cases in your hands. So, number one, adjusting the family and the girl's expectations are very important. So to tell her that she will come off Lupron and not have to do vaginal dilations, I think it's very unlikely. At 12 years old, to offer hysterectomy here in the United States is very complex. You need ethical consultation. You have to justify it's complex. Now, I think if the girl is not willing to do what it takes, she should continue on Lupron. Otherwise, her symptoms are just going to be worse. Currently, what I see, number one, this patient, the chances of her having spontaneous pregnancy are close to zero. This is a patient that has a partial vaginal replacement with bowel. We have only seen in the literature one case of ectopic pregnancy in a patient that had a partial vaginal replacement with bowel. So it's unlikely. She has tubal disease, which is another reason for infertility in cloacas. She had multiple pelvis operations. She has an obstructed uterus. So I think the chances that she will have natural pregnancy is very low. And the reason why I'm bringing this up is just there is a chance she will end up with a hemihysterectomy. Now, why she doesn't have, the only way to know if the uterus that it's connected is draining would be to take her off Lupron, but she will become symptomatic. And it's very important that this family has a trusting relationship with one center and that they are going to follow the instructions, because it seems that this family has been hearing so many different opinions. And the minute you take her from the menstrual suppression, she will accumulate blood probably in the uterus that it's not connected, because that for sure has accumulated already. So that will require a drain. And if the family doesn't trust the center that she is, she will have to search for other opinions, and then it's unsafe for the child. So I think the other portion that made me sad about this case is that during the reconstruction, they were, first of all, if you have a 5 centimeters common channel, you should not try a urogenital mobilization. That it's very unlikely that this vagina would reach, and the surgeon should have been prepared to do a vaginal replacement at that time. Usually, we don't recommend funny-steel incisions for colorectal cases. These vaginas and bladder are very high. You need full access, so not a funny-steel incision. So I think this patient at this moment needs a vaginoscopy to see if you can clearly see the cervix. I don't know why she's on vaginal dilation. If that means that when she stops the vaginal dilation, this vagina is closed, this patient needs a reoperation. So it's a very complex case, and what I'm mainly concerned from what I hear is that the family currently is having a problem of who to trust and where do they want their care. The only thing is they should choose one, but they have to understand that whatever scenario they do, if they stop the Lupron, she will become symptomatic. If they do vaginal reconstruction, she will need maneuvers to keep the tract open. So it's just that the easy solution that they want, I don't want to do vaginal dilation, I don't want to be on Lupron, and I want to have normal menstrual flow. I think it's hard. So I think that's the main concern that I have. Do you want to comment? Any other questions? Dr. Abdullah, what other questions do you have?
No, I mean, so when I met them after reviewing everything, I arranged to do a vaginoscopy and spoke to them that we should. I'm so happy to hear you say that, because I said that they, in my sense, is that the obstruct or the uterus that's not connected, because I believe there is one cervix, is not draining because it's obstructed, like almost like a Y, and so it's not able to drain, and that subsequently that hemiuterus needs to come out. And I agree completely about managing the expectations. I had arranged for them to do a vaginoscopy, and I tried to find a gynecologist, a pediatric gynecologist that is familiar with this. If I'm very frank, we don't have a lot of pediatric gynecologists that are comfortable with that space in many parts of our country. And so after doing that, I said, I don't think that you need yet another center involved. So I communicated with Sick Kids. I communicated with the other center where she came from. And I said that I would present her to you guys to say, let me just make sure that one, I'm not crazy, and that two, that we could at least present her a coherent argument for what is going on, and then decide on. I think if they could, you hit it right on the head. If there was trust in the center and in the plan, they could see something through. But I think because they don't feel, they lost therapeutic relationship, and because right now really her problems are gynecological and there's not strong pediatric gynae, she's struggling because she's being bumped around between different urologists, pediatric surgeons, trying to effectively deal with things that a comprehensive center should be dealing with.
Yeah, and the reality is, in this case, it's very important to have experienced gynecology involved, because sometimes, for example, the ovarian cysts, the ovary and the fallopian tubes are completely fused together. You cannot even tell what is what. So this is a family. Of course, we all try to preserve ovary at all costs. Nobody remove ovaries from just an ovarian cyst. But sometimes, and we had a case in which we could not tell what is what, and the pathology found that there was an ovary in that huge mass that we couldn't tell what it is. And I feel that in a family like that, this would be not well taken. So it's very important to set up family expectations and let them choose where do they want to go. And if all the centers in Canada agree upon this is the management we are all offering, then I think it would be better for the patient.
I have a feeling that I might be hiring a bus and putting a bunch of patients and families and driving to Colorado.
Yeah, and then you come with them.
Exactly.
Perfect. I think we have passed our time. So thank you all for joining us today. It was a very productive meeting, and we look forward to see you again next month. I'm not going to mention the countries because we are very, very late, and I know everybody has a lot of work. So thank you. Bye-bye.